Munoz on the phone. She is with the Division of HIV and STD programs, as you can see. So I'm going to hand it over to her.
Well, good morning, everyone. My name is Monica Munoz, and I am a public health nurse with the Department of Los Angeles County Department of Public Health in the Division of HIV and STD programs. And I am the nurse manager overseeing all of the clinical and nursing issues in LA County. So I appreciate you allowing me to present to you this morning. And I'm going to be talking a bit about prenatal and congenital syphilis in LA County. So as a background, there have been increases in female syphilis cases, which have led to a dramatic increase of congenital syphilis in LA County. Congenital syphilis is a preventable condition that results from untreated syphilis during pregnancy with potentially severe consequences for infected infants. Congenital syphilis can lead to stillbirth, neonatal death, birth defects involving the nervous system, or bones, blindness, or death, skin lesions and scarring, and other clinical manifestations. Fetal infection can occur during any trimester of pregnancy and during any stage of syphilis. So let's go ahead and get started. So hopefully by the end of this presentation, you will have a clear understanding of prenatal syphilis and congenital syphilis trends in LA County, describe what characteristics place females at risk, and have at least one idea how we can collaborate with each other on trying to control congenital syphilis in LA County. So in order to know how this happened, how did we get here? We need to know a little bit about backgrounds and trends. So syphilis during pregnancy, there is an estimated 8,000 cases per year in the U.S. Pregnant women appear to be more susceptible to the infection, possibly due to the physiological changes that occur during pregnancy. Does it look different when you're pregnant versus non-pregnant? It looks exactly the same. So any women that actually test positive for syphilis during pregnancy, the red flag should go up and she should be carefully evaluated and considered for treatment. So how does California look in comparison to like the United States, or how does LA County look in comparison to California? So in LA County, we are actually having a high number of congenital syphilis cases. So we see that there's certain health jurisdictions that are affected more than others. So in LA County, for example, in 2016, we had 37 confirmed cases of congenital syphilis, while in Fresno, they are actually having more cases with 51 cases. So not all areas in California are being affected, more so some than others. So in California versus the United States, we are actually seeing higher rates of congenital syphilis in California than in the United States. So we can kind of see how the spikes have been going on versus, being able to reach our 2020 objectives. So we're nowhere near that now. So California constituted 33% of all cases of congenital syphilis in the entire United States, and we are ranked the second highest. We have approximately something like over 200 cases in California of congenital syphilis. I don't want to take out my training, sorry guys. Okay, so here I have a nice representation over the years of the total number of pregnant women and the total number of women that are diagnosed with syphilis, and the yellow or the orange bar represents the number of congenital syphilis. So for 2017, we had a total of 43 congenital syphilis cases, which is very alarming, and this is a real public health issue that we're seeing here in LA County. At the program level, we have been working with heat maps to see, for LA County alone, is it affecting certain areas more so than others? And we do see that. We do see that certain spas are being affected more than others. For example, Spa 4, which is your metro area. Then you have your Spa 3, which is your San Gabriel Valley area, and Spa 6, which is like your south area, your Compton, your Inglewood area. That doesn't mean that there is not congenital syphilis cases, but there are areas that are being affected more so than others. So I'd like to share with you some of the maternal characteristics that we are seeing out of the mommies that are actually delivering these congenital syphilis babies. So this is actually the moms. It's not, the total number of pregnant women. So some of the maternal characteristics that we do see, like with regards to race and ethnicity, is we're seeing 46% of them are African American, followed by 38% of them are Latina. And then the other ethnicities are way less. So primarily affecting African American and Latina women. This is another thing that's really alarming about these women, is that 38% of them are not seeking any prenatal care, meaning that they are showing up in the hospital having a baby with no prenatal care. And then 18% of them have actually enter prenatal care in the third trimester. So that is about 56% of these women are either having no prenatal care or entering care way, way, way too late. And so that is, of concern as well, of why are they, not going into prenatal care. Another thing that we're seeing in the women that deliver these babies is that there is, drug use occurring in pregnancy, meaning that there's, only 33% of them are reporting no drug use. Also, the way that we're able to get this information is by toxicology in the hospital, because self-reporting of drug use is actually very low. So because we know that they are not having any prenatal care, the moment that they show up in one of these delivering hospitals, there's a toxicology panel that is drawn on them, as well as an HIV, in order to see if there's any drug use. So this, is very alarming, and there's polysubstance abuse going on. So we see, a combination of close to 10% of them using meth and marijuana, 28% meth, 8% cocaine. So with the opiate use in LA County, we haven't seen so much of heroin use, but we are seeing, meth and cocaine frequently being used by these women. Another thing that we see in our females that are delivering these congenital syphilis cases is that there is a high rate of incarceration. So 46% of these women have had some history of incarceration, at least within 2 years of their diagnosis and delivering a congenital syphilis baby. So we're starting to see some, some trend here, high history of incarceration, as well as drug use and a lack of prenatal care. So to recap, who is at risk for syphilis in LA County? It is your Latina and African American women. Certain geographical areas such as SPA 3, 4, and 6. Situations where partners may have other partners. And this is a really hard one to gauge, because who really knows that their partners having other partners? Accessing prenatal care late at all, having many missed visits, exchanging sex for money, shelter, or other things of value to them, drug use, And in some situations, we have seen some of our females being homeless and having serious mental illness as well. So I'd like to start going on, into how is syphilis diagnosed, what types of tests, what are the treatments that we use for this. So here I have, this is the microorganism that causes syphilis. It's called Treponema pallidum. So basically, when this little squiggly guy goes into a mucous membrane, that's where the classical chancre forms. So pretty much it burrows into a mucous membrane, being, it could be inside somebody's mouth, somebody's, imagine the tip of somebody's finger. And during this presentation, I might actually be using some, anatomical parts, or I might be showing you actually, some pictures of how syphilis looks. And so, I don't want you to be offended, but it's important to actually see it. So I'm kind of giving you a warning right now so you won't be shocked, okay? All right. So here's the first shocking picture. Syphilis diagnosis is not done by lab alone. Unfortunately, syphilis is called the great imitator. It looks like something as it might look like nothing. So some of the clients that are infected with syphilis, they absolutely do not know anything, while some of them might actually have some of the classical symptoms of syphilis, such as the palmar plantar rash, which is the first picture we have here. Other clients may have these things called mucus patches that develop inside their tongue. Now this picture, the next one with the penis, is actually the classical chancre. And sometimes it is confused with herpes simplex virus, because if there's touching skin folds, what's going to happen is you're going to have these kissing chancres, which means that just the surrounding skin tissues become infected. And so this can throw off a lot of our providers. The next one is called condyloma lata. And it looks very, very similar to genital warts. But this particular one is very specific to secondary syphilis. And this one, believe it or not, the moment that you treat somebody with, the recommended treatment, which is penicillin, it just spontaneously resolves. So that's how we know, this is like condyloma lata, because it just responds immediately to the treatment. So unfortunately, the lab alone will never diagnose syphilis, and we need to know some information related to the patient's physical exam, their sexual and risk history, as well as other medical conditions, because syphilis is also one of those STDs that sometimes may be a biological false positive, meaning, even the test, will throw us off a little bit. And I'm going to go ahead and talk about that in a little bit as well. So how does one go about staging syphilis? So here I'm going to go ahead and present to you what is called the syphilis staging flow chart. And according to the CDC, and as well as in the Department of Public Health, this is how we actually stage it and how we end up calling it either a primary, a secondary, or a latent. And this, if we can understand this, we have become like the masters of staging syphilis. But it's a little, it takes a little bit of practice. So the first question that we ask ourselves is, does the client have signs or symptoms? And if the client does actually have signs and symptoms, we move to the yes section of this. Does the client have the actual primary sore, which is called the chancre, that painless sore? If they do, and the doctor actually sees it, that's what means primary. It doesn't mean the primary time or the first time. It means we can actually see a chancre. Now, if the client has a history of the rash, either being palm or plantar, the macular papular rash, or the condyloma. This is what is termed as secondary syphilis. In order to have either primary or secondary, it must fit into one of these, into these buckets. And if it doesn't, then we cannot call it that. Now, when the client says, I don't have any symptoms, or I don't know what you're talking about, then that's when we start thinking that it is an older infection, and it is called latent syphilis. Now, within latent syphilis, you could be early latent or late latent. So how do we classify somebody as having syphilis as less than 1 year and being early latent? Well, we have to have some information, such as negative syphilis serology within the last year. So that means that maybe she had a baby within the last year, and we have a negative test result on her. Then we can say, you know what, we think you might have been infected with syphilis within the last year. Or they might actually say something like, my partner was diagnosed with early syphilis, and therefore you become an early latent syphilis. Or imagine if somebody has had a history of having syphilis. Those titers, or that, numerical representation that they call it, the RPR, and it goes 1:1, 1:2, 1:4, and there are RPRs that are very, very high. So imagine somebody actually has a history of syphilis. After they are successfully treated, their number becomes a stable number, which is what we call serofasting. So whenever anybody jumps a fourfold higher than what was their stable number, we know that they have been reinfected. And so then we can call them early latent syphilis. Now, the one that most of our clients are going to fall into is the one that they don't know anything. You ask them, when was the last time you were screened for syphilis? I don't know. So sometimes we can gauge our clients by asking them, when was the last time you had a baby? And then maybe they'll say something like, 2 years ago. Did anybody ever tell you anything about syphilis? And then they'll say something like, no, I was never told anything. And so maybe we can start pinpointing when they became infected. And but that's when our clients become late latent. They have absolutely no symptoms. We don't have any negative syphilis serology. They don't know that they've been contacts to anybody. And then maybe we don't even have a baseline titer to begin with. One of the recommendations that we have whenever anybody tests positive for syphilis is that they should also be tested for HIV, because, syphilis and HIV actually do go hand in hand together. And we see it very commonly in our men who have sex with men population that, there's a high incidence. So in pregnancy, we actually do recommend as well a HIV screening. So I want to go into what is the serology tests that are commonly used to diagnose syphilis. Mostly I want you to have these slides so that maybe in the future you might need to refer to them. But typically there are testing algorithms that we use for screening. So the first test that is typically done is that RPR, the rapid plasma reagent, or in the old days, they used to call it the VDRL. And they still use it, so that's why I have included it. So typically, the female or the client will get a blood test drawn, and prenatal providers will send it out. And according to state law, all females, when they start prenatal care, their first prenatal visit, we must get an RPR. So this is how the whole thing gets started. So the blood test goes in, to the lab, it gets, run. And if it's negative, that means that it's nothing. The client doesn't have, even a positive RPR. Every now and then, there are false negatives, and but that's kind of rare. The only way that we think something might be false negative is if you have a client in front of you that's obviously showing a lot of symptoms of syphilis. Imagine the rash, the mucus patches, and somehow their blood test is negative. We actually think it's a false negative. But just, for training purposes, when an RPR is negative, that means that, there's really nothing to worry about. Now, every now and then, when people do the RPR, or the lab does the RPR, and it is positive, then we need to confirm this test. So the RPR tests for things that look like treponema. It is not considered to be like the definitive diagnostic test, but when an RPR is positive, then it must be confirmed with a treponemal test, the one that causes the STD type syphilis. So sometimes people are what is known as a biological false positive, meaning for some reason their RPR is showing to be positive, but when they run the actual treponemal test that causes treponemal pallidum, the one that causes syphilis, it is a BSP. And sometimes there are reasons for BSP. And I think in my next slide, I'll explain about BSP. So how about if it's positive? That means that the person that we have just tested has tested RPR positive, and they have tested treponemal positive, meaning that they do have syphilis and they have the disease. And that's where we talk to the patient and we start the whole staging process. So let me go ahead and, just go into the BSP for a second. There are reasons why people are BSPs. So, you know what? It's unfortunate. Sometimes when females are pregnant, pregnancy will throw off what is known as a BSP, recent viral illness, recent immunization, a history of IV drug use for some reason. It will make your RPR positive, but the actual confirmatory test will be negative, which is what is known as BSP. Okay, so let me go ahead and start getting, you oriented with the screening guidelines for females. So in LA County, we are adopting more rigorous screening guidelines than usually recommended. So let me go ahead and show you. So in 2017, LA County Department of Public Health has provided recommendations that all pregnant women should be screened for syphilis at their first prenatal visit, at their trimester, which usually starts at 28 weeks, and at delivery. And why is that so? Because a lot of our females that actually do get prenatal care, by the time that they deliver, they are reinfected or they become infected. Why at their trimester? Because if we can catch it at their trimester, it actually gives us enough time to treat them and get them ready for them to deliver uninfected. And then the baby will not have congenital syphilis. In LA County, believe it or not, we did not have syphilis screening recommendations for women of childbearing age. So right now the recommendation is all women between the ages of 15 and 44 years of age, they should be screened for syphilis at least once in their lifetime or dependent on risk. So what does that mean? That means that, certain females may not have children or will never get pregnant, so they won't go through the routine syphilis screening, which is required during pregnancy. So the recommendation is at least sometime in their lifetime they should get screened, or if they engage in more risky behavior, they should be screened more frequently. Other screening recommendations that, are also in effect is any women that have no prenatal care, they should not be discharged from the hospital before we have syphilis screening results. And so typically what happens is she shows up in the hospital and she's, having literally a baby. And so they order stat RPR, HIV, toxicology, and I know that they do a lot of the hepatitis as well. And so a lot of the times our babies are released before these syphilis results are in, and that merits for the baby to be brought back into the hospital for a full treatment and evaluation for congenital syphilis. So that's one of the things that we would like to prevent as well. Okay. So what is the treatment for syphilis? Well, during pregnancy, penicillin is the only drug that can be used. There is absolutely no alternative. There is no oral medication that I can give to a pregnant female and it'll work. The only one is actually using, the penicillin intramuscular injection. The treatment, is it different for pregnant versus non-pregnant? No, it's exactly the same. So 1 dose of benzathine penicillin G is required to treat early syphilis. However, some experts actually give them 2 shots, and they're usually 2.4 million units. And it goes into usually the gluteal muscle, And I have heard, I'll be honest, that it does hurt, but this is the only treatment that we can use for pregnancy. And if they happen to be allergic to penicillin, there is no other alternative than to have them undergo a process called penicillin desensitization. Or now there is actually a skin test that is provided by like an allergy and immunology department that we can actually test to see if they are actually allergic to penicillin. It is estimated that at least about, close to 90% of people reporting penicillin allergy, they're actually not allergic to penicillin. So by providing not a blood test, but a skin test, we can actually correct the medical record permanently if in fact she is not allergic. So we can take out like a penicillin allergy if in reality she is not allergic. But if she is allergic, then, we have to undergo what is known as penicillin desen. So this is actually like an admission where they slowly start administering small doses of penicillin over like a 24-hour period. And it comes to the point that the client will be able to handle the full dose, and that's when they actually give them an IM. And if any additional follow-up is required, usually the hospital will continue to follow up with her every week if she should need additional treatments and so forth. At the Division of HIV and STD programs, if for some reason some of your clients would require penicillin desen, you can give us a call and we can arrange this through LAC USC Medical Center. And we could work with their insurance or Medi-Cal to get this covered. So in LA County, we have a total of 12 free STD clinics. It's not only STD, we actually do free immunization as well as TB, for TB clients. And we have full STD clinics that are free of cost. So I'm going to go ahead and share with you some of the clinics that we do have. Now, even though we do have 12, all of the schedules are subject to change. And some clinics are closed during the holidays. And so, we should advise our clients, to call before they show up and to, make sure that there is a clinic. Some of them actually work by appointment only. And, even though you might see like ranges of time, imagine if they do have two clinic schedules, one at, that starts at 8 o'clock and one that starts at 12 o'clock. We always recommend the clients to show up early instead of showing, at the later part of the clinic session when they might not be seen. So the treatments that we use at these clinics, they've been developed in order so that by the time the client walks out of the clinic, they are fully treated. Meaning, imagine you have a client that has chlamydia or gonorrhea. We don't want to give lengthy treatments, that may just cause non-compliance and they forget to take their medication. So we give them the azithromycin, which are the 4 pills plus the injection. And so by the time they walk out, they have treatment, as well as we also give partner treatment packs, which is called expedited partner therapy. So in the state of California, in order for doctors to treat partners, they don't even have to see them. So we do have these types of treatments in our STD clinics. So we do have an STD hotline that you can, call and get more information, as well as going to our website. So on our website, we do have, the STD clinic registration schedule. So as you can see, like we have a clinic in the Antelope Valley, San Fernando Valley, San Gabriel, the Metropolitan LA, which is over on Temple and Figueroa, West LA, South LA, as well as East LA, and then over in the Harbor area. So as we can see, some of our clinics are, they're up and running every day with 2 sessions, while some, for example, at Torrance Health Center, you will only see 1 clinic. And so my recommendation is that they, the client or maybe the case manager calls ahead of time to see how, what's the best way of getting our clients into these clinics. All right. So, I've actually put, the dates of operation for like Antelope, San Fernando, Pomona, Metropolitan, Hollywood Wilshire Health Center, over in West LA, Sims Manberg Health Center, as well as their addresses and their phone numbers. South LA, Ruth Temple Health Center, Whittier Health Center, Curtis Tucker Health Center, and then Torrance Health Center. Now, I would love for these clinics to actually be open, at constant hours, because as you can see, some of these clinics only have one day per week, while others have every day. And, I must admit that this is probably one of the most, the hardest things about working with our STD clinics is really knowing the clinic that you're going to be referring in order to ensure that the client is seen on the day. Okay, so from here, I want to talk about some of the congenital syphilis activities that we have in the community, and I'll, kind of get you oriented on that. So we have this thing called the Public Health Action Kit. For the past year, the Division of Public Health and the Division of HIV and STD programs, we've been working on developing public health detailing, a kit that a professional marketing agency has started as of this week, visiting 600 LA County providers, those being under the Comprehensive Perinatal Service Provider Network, all of the providers that have seen clients that have been diagnosed with syphilis or have had an outcome of congenital syphilis. So we're going according to priority. So we're going to be visiting 600 providers with a follow-up visit in 6 weeks. So our kits is going to include, a letter, from our director of our division, which is Mario Perez, in, alerting the providers of, with the full support of the Board of Supervisors, we are urging you to increase your screening, take thorough sexual histories, screen all women of childbearing age, screen all pregnant women, during the first, third, and a delivery, and stage accordingly. Now, this yellow poster here is actually the cover of our public health detailing kit. It provides some really excellent resources regarding things that we spoke about earlier today, such as screening, staging, treatment, taking sexual histories, the posters, frequently asked questions. And these are for the provider as well as the patient. And also, giving them a copy of our STD screening recommendations, as well as the treatment recommendations. It also provides, a syphilis webinar CME opportunity for doctors to take, and it reviews the epidemiology of syphilis, clinical manifestations, diagnostic approaches, staging, and the characteristics of congenital syphilis. So at the end of this presentation, well, actually not the end, but now, if any one of you is interested in receiving one of these public health detailing kits, they're excellent. Just let me know, and, I'll get it out to you, because I think it's a really, really great kit, not only to share with providers within possibly your facilities, or maybe if you have a question, as you're seeing one of your clients, you could refer to it and, get the answer for it, or possibly give them the resource, or, just raise the red flag that, what, I think you guys might be missing congenital syphilis, or this woman may not have a result, and she's leaving, the hospital, and, just maybe for proactive reasons. I don't know. So social marketing is widely used to influence public health behavior. In August, in LA County, you're going to start seeing our social marketing campaign come alive. And this is, the goals of this social marketing campaign is really to increase awareness about syphilis in LA County. It's going to be community outreach. It's going to be materials targeting highest risk LA County residents. So don't be surprised, in the billboards, or we're going to start, wrapping buses and just putting these, highly visible posters that kind of look like street signs. And this, marketing campaign was graciously given to us by Pima County. So when we started noticing that there was a problem with, syphilis in women and congenital syphilis, we started exploring how are we going to get the news out to the public. And this, after researching a whole bunch of social marketing campaigns, we thought that this one might be the one. And it's called Think Syphilis. It has these street signs of, like a woman with a baby, and perinatal syphilis, the palmar plantar rash, and it actually has that red sword, that little red dot, which represents the chancre. And, it has a phone number of, hey, if you need more information, give us a call if you'd like to screen, and so forth. So this is going to be very simple messaging, increasing testing, like I mentioned, large-scale images, large billboards, Because of funding, we're going to, put temporary placement in high traffic areas, meaning like buses, and we're really going to saturate neighborhoods with the images of this. That rash that you might see might be syphilis, go get tested. And we're going to hopefully time our release with other partners to increase visibility. So as I mentioned, we're going to do a lot of advertising and a lot more advertising in those districts with areas with the highest rates of syphilis, meaning like spas, 3, 4, and spa 6. Other things that we're doing here at the Division of HIV and STD Programs is, if we recall the slide of the percentage of women that have history of incarceration, this might be a great way of actually getting them tested. So we are actually piloting a rapid syphilis testing project over at CRDF. CRDF is the jail that houses female inmates. And so this is actually a collaboration between the LA Sheriff's Department, the Division of HIV and STD Programs, as well as the Department of Health Services. So we're actually performing it's almost like a glucose finger stick, and we can perform a treponemal test, meaning we're actually looking for the actual T. pallidum, the one that actually causes the STD syphilis one, and within 10 minutes we know if she has the antibodies. And at that time, we're going to do more testing and screening, and then we're going to facilitate the treatment within the jail. And this is actually really important, because if we can catch them before they are released, then, they may, even if they should be pregnant, they possibly will not deliver while being infected with syphilis. And so we see a lot of promise in, testing in the jail facilities for women. Another area that we're starting to work with are substance abuse and addiction programs, because we know that people that abuse or are addicted to, either an illicit substance or alcohol, and if they are actually seeking ways to recover, what better place to actually test and treat? And so we are looking at working with the Matrix Institute to actually place, frequent or stable type of testing in these areas in order to catch them, as we know that many of our females that actually go to deliver a congenital syphilis baby are actually, currently using many drugs. Another area that we're exploring is actually homeless encampments. Many of us, as we drive, the 101 or many of our freeways, we see a lot of these encampments. And so we can actually go and make contact with, the homeless encampments and screen them, deliver results, and then provide treatment or referral services to the people that live in these homeless encampments. So in LA County, we use public health nursing a lot. Because it is syphilis, all women of childbearing age that are diagnosed with syphilis are actually assigned to a case manager, which is a public health nurse. And he or she will be the ones actually making contact with clients and making sure that they, go in and get treated, facilitate treatment, as well as educate and try to get them, try to get information with regards to their sexual partners. So I just kind of wanted to share with you how public health nursing and the disease investigation process works. So the Division of HIV and STD Programs, we're the surveillance program. So we're the ones that are actually receiving all of these positive, CMRs and these positive results. In turn, the group of nurses that I work with, we turn them around within 1 to 2 days, and we route them to one of the 14 health districts where the public health nurses are housed, and we provide the full set of recommendations as well as necessary treatment and follow-up. And then the 14 health districts, there are about 200 public health nurses out there. The cases assigned to them, they set priority to how fast they need to work the case, and the standard is that all of these cases must be closed within 30 days of assignment. So that includes treatment, education, partner elicitation. And at the same time, we have, public health investigator assistance. So imagine if the client doesn't want to work with a public health nurse, then we can actually escalate it to public health investigators to help us locate her in order to treat her. So currently in LA County, we have a certain, we've been lucky to work with, collaborators on this, such as public health, which is community health services with WIC, Nurse Family Partnership, the Department of Health Services, MCEH, and of course, like with agencies like you. We are exploring, having more collaborations in the work, like working with agencies that work with women that are homeless, or agencies that are working with women who use drugs, agencies that serve women and children, more public and private clinic collaborations, and of course, nurses like you. So if during the course of this presentation, you see that there is a possibility of a collaboration, let me know, because I am eager to always be collaborating with other programs and nurses as well. So this is where I leave you. How can your program help, or how can I help? Well, the mere fact that we live and reside maybe in LA County, or that we have contact with females of childbearing age, or contact with, these hospitals that are delivering these babies or women that are infected with syphilis, it is an opportunity that we can actually talk to these females about, hey, have you been screened for syphilis, or at least once in your lifetime, or during your pregnancy, have you been screened for syphilis? Do you know your result? Questions like these. So really the take-home points of congenital syphilis in California are female syphilis and congenital syphilis cases are in a rise in California. Most congenital syphilis cases can and should be prevented. Screen for syphilis and link pregnant patients to prenatal care. Treat syphilis as soon as possible and report to your local health department. Ensure partners are treated to prevent infection, reinfection. Evaluate infants at risk for congenital syphilis. So I'd like to thank you today for allowing me to present to you. And if you should have any questions, here is my contact information, my phone number. If for some reason you can't get me on my phone number, I have a general number. Usually I'm walking around the unit as well. And, this general number is actually great because this is the warm line. And if, imagine if you're working a case and you'd like to know if the client has a history, a past history, or if you're seeing something that, is of concern, you could always, give us a call and we could always help you. And here's my email as well. So I thank you for your attention today, and I do wish you a great, wonderful day. And if you have any questions, I am here to answer your questions. Thank you.
Thank you, Monica. Does anyone have any questions? If you do, please put them in the chat box on the webinar, and Monica will be able to read them and answer them. Why don't I go ahead and unmute everyone? That way we can have a conversation if that would be easier. It doesn't look like there's too many of us on the phone, so just as a warning, I am unmuting everyone. All right, so does anyone have any questions for Monica? You are now unmuted.
I do. I have a question.
All right, please go ahead.
Okay, so if a woman is treated for syphilis, let's say at the end of the pregnancy, but she had it at the beginning of the pregnancy, what the consequences on the fetus? Is the fetus treated as well, or will the fetus
will the fetus have something? Okay, so the answer is, penicillin is the only one that passes the placenta barrier. So yes, with the moment that you treat the mommy, you treat the baby. And so the baby will be fine and have no long-term consequences. Now, there is certain follow-up that is needed. And usually, once she's caught early in pregnancy, usually doctors do follow up with that RPR monthly to make sure that it goes down and that she's not reinfected.
And also, can you talk about tertiary syphilis?
Yeah, tertiary syphilis is like very old syphilis, by the way. It's usually, I'm going to tell you, probably 20 plus, years old. And it actually doesn't occur anymore because of a lot of the incidental antibiotic treatments that we've taken. Imagine if we take a course of amoxi or a course of a Zithro, I have hardly ever heard it. Now, I do hear about neurosyphilis a lot more than I used to, which, we used to think neurosyphilis would be like tertiary syphilis, but neurosyphilis can occur at any stage of syphilis, so you could be an early syphilis and have, neurosyphilis.
Oh, okay.
Because, if you think about syphilis, it's a systemic infection. So that means that it's circulating all of your bloodstream, and it can pass through the blood-brain barrier, meaning up, your spinal cord, and give you neuro as well.
Thank you.
Oh, you're welcome.
And the treponemal test is a blood test?
Yes, the treponemal test is a blood test. So typically, whenever somebody, imagine they start prenatal care, they draw one vial, and so they order the RPR, and typically it reflects us to the confirmatory, which is the treponemal test.
Okay.
So this is
Jen. So you said also so who is the number one? You said California is the second highest rate. Who is number one?
Yeah. Louisiana.
Oh, Louisiana.
Yeah, Louisiana. And believe it or not, we have the highest number of congenital syphilis, but, because they put it through a mathematical equation based on the population, so LA County, we have such a huge population of like over 10 million. That even though we have the highest numbers, we still don't have the highest rate. So Louisiana is the number one.
Wow. Okay.
Thanks, Blondine. I heard there was someone else trying to ask a question.
Yes, this is Jan French, and I was just wondering, since we have Welcome Baby hospitals in the regions that are having the highest prevalence of congenital syphilis, I'm wondering if that is something that the nurses are seeing reported on their hospital transfer tab, and or Monica, if you would recommend that the Welcome Baby sites maybe make it a priority in especially those regions to investigate what that result for the mom so that they could help follow up in the home visits in the postpartum period and make sure that they're getting the treatment that they need.
Oh my God, I think it's incredibly important because I was looking at the roster of hospitals that the Welcome Baby works with, and it just aligns with, where the cases are. And I would recommend that Welcome Baby make it a priority. That make it a priority. And, I'd be willing to work with, all of the hospitals of incorporating it and or providing the, the materials like the public health detailing kit, any education, ground rounds, or so forth.
So for the nurses on the call, have you received that information on the hospital transfer information for any of your clients, either a negative or a positive?
This is Tommy from St. Francis, and we have not seen anything.
Thank you, Tommy.
As a note, could you please mute your phone if you are not talking? Thank you. Does anyone have any other comments or questions?
This is Tanya from MLK and Centinela. We rarely see the results, negative or positive also. And that would be good if we did.
Yeah, I think that would be actually, you know what? In 2014, this is the first time we happened to see the real spike occur. And one of our hospitals that actually had the highest numbers was at Centinela, where there's a lot of, I'm not going to say there's a lot of women, but there's some women that would walk into Centinela just having a baby without prenatal care. And, one of I don't know who sees these results, to be honest with you, but I do know that the moment that we do receive the positive test, that, we contact the infection control provider. And sometimes, I wish that we would have more of a link between like the actual nurses or the actual departments that are with the patient, instead of the ICP, because it seems like they're working on another type of priority as well.
And just for your information, Monica, this is Jen French again. Our nurses work out in the field. The Welcome Baby nurses work out in the field, and they just get some of the information transferred from the hospital records. So I think we'll need to think with the program managers in terms of how it might be possible for us to make that link from the hospital liaisons that see the clients, the Welcome Baby clients, and then transfer the information to the nurses.
Yeah. You know what? One of the things that I do know, this is what I do know about, delivery RPRs, because I've met with some hospitals, this is what they've told me. They've told me that the only way that they run in a delivery RPR is that if that OB record, how those, that little card they give you when you're going to have a baby that records all of your OB history. That's the only reason why they run an RPR. I don't think they run it on all women, but they only run it on the ones where it said, had a history of syphilis during pregnancy. And so it would, maybe that could be something that could trigger, the nurses and, at your programs, at least if they have a positive syphilis test or a positive history of being treated for syphilis.
Great. Thank you.
Mm-hmm.
Are there any other questions?
Well, Monica, can you describe the symptoms of congenital syphilis on the baby? Like refresh my memory. I know there is CNS deficiency, but other than that, I don't remember.
Okay, so definitely, you know what? Sometimes these poor babies, even before they come out, you know, they have suffered like, you know, in utero strokes, or so, you know, that would be one of the things when they come out. You know, they would have a lot of some of the babies actually have the rashes, like those secondary rashes that, you know, adults have. They'll be born with those rashes. They have these thing called syphilitic rhinitis, which, you know, it looks like the snuffles, and you know, they just have this persistent runny nose type of thing. Another thing, you know, so another thing that we've noticed is a lot of the times these babies are just born looking beautiful and they look healthy, and they take them home, and then, you know, within a few weeks they bring the baby back because the baby has stopped moving his legs and arms. So they get like these paresthesias that look like, you know, literally like tertiary, you know, syphilis, where they have, you know, like stiffness in their, you know, like little arms and legs and cannot move. So once, like, imagine if they let it go, you know, a long time, once their teeth start growing out, the curvatures of the teeth do not look normal. We have these things called mulberry molars. So I guess to describe it, it looks like, you know, they have like berries, like, you know, type teeth, you know, instead of having, you know, the little curvatures that we typically have. Some of them are, you know, go blind and they go deaf as well. And once they start walking and their little bones really start developing, you start noticing these really abnormal curvatures in the leg bones. Like they're called saber shins, you know, and just, you know, just abnormal looking bones and teeth. And, you know, I'm asked, are these things reversible once you treat them? I think once they show, you know what, they're not reversible.
They're not, okay. And it also affects brain development?
It probably affects development. It probably affects a lot of things, to be honest with you. And they usually are followed up, you know, for life by the, what's that program, CCS? You know, usually they need, probably for the rest of their life if they have real lifelong problems.
Thank you.
Oh, you're welcome.
Any other questions for Monica? Okay, so as you can see, her contact information is on the screen right now. Thank you so much, Monica. This has been a really helpful and informative webinar. We have been recording it, so we will send out the recording, as well as, Monica, would it be okay if we share your slides as well?
Sure, definitely. Definitely use my slides, get the information out. If you're interested in, you know, me sending you one of these details, they're really great. They're beautiful, and we spend like a whole year putting it together and organizing it in such a way that it's very easy, and it has like a little table of contents so you could just grab what you need, and, you know, also sharing the materials with your patients for your home visitation, you know. And then, you know, I'm open for, you know, education, in-servicing, anything that you guys should need.
Wonderful. Thank you so much.
Oh, thank you so much for having me. I do appreciate it.